Now for pediatric physical exam. Assessing a child is very different than assessing adults, so be sure to write down these 4 key points. Number 1, we always interact with the parents first and the child second. This helps to build trust with the child and the family. Number 2, encourage the parent to be involved with the child. Huge NCLEX tip. Be sure to write that down. For example, let the child sit on the parent's lap during the physical assessment. And number 3, communicate with age-appropriate, simple language, understood by both the parent as well as the child. And number 4, we always keep medical equipment out of sight. This will help to decrease unneeded stress and anxiety, which augments the vital signs. And number 5, invasive procedures are always saved for very last. For example, ear exams as well as blood pressure cuffs. So as a general rule on the NCLEX, we always do the least invasive first, like observing respiratory rate without touching the child. And we always save the most invasive stuff for very, very last, like ear exams, vital signs, and even introducing new medical equipment, but always very last, as these will typically frighten the child and augment the vital signs. So ATI had a question here. Physical examination of a toddler. Appropriate nursing interventions. Keep the medical equipment out of the toddler's sight until it's needed. Yes, always saving it for very last. Now, a top missed NCLEX question about assessment techniques. So here we go. While preparing to perform a physical assessment on a 22-month-old child, the nurse should complete the following actions in which order. Now, this is an order response question that over 70% of students got wrong. So don't let the NCLEX trick you here. Just think least invasive first and build that trust and rapport. Then progress into the most invasive procedures like vital signs. Since, let's be honest, the blood pressure machine, pulse ox, and thermometer can be downright scary for the child. So looking at our unordered options here, we're going to drag and drop into an order response. So the number 1 thing that we should do here is number 4. Interact with the parent first. Number 2 is use a toy to play with the child, build that rapport. And number 1 here, or basically number 3, is take the child's weight and height. And then number 4, which is our option number 5 here, listen to the heart and lung sounds. And then very lastly, obtain the vital signs. Yes, as you can see, we're building rapport first and slowly progressing into the most invasive procedures. Now, switching gears for infants 0 to 12 months, specifically for physical exam. For the growth, we look at height. Now, the height should be at least 1 inch per month. They should have 50% increase at 12 months. And for the weight, huge NCLEX tip, be sure to write this down. It doubles at 6 months. Again, this is the most tested time and time again. Now, it also triples at 12 months. So for example, if a newborn baby weighs around 6 pounds, well then at 6 months it should be doubled at 12 pounds. And at 12 months, it's going to be 18 pounds. Now, anything under these benchmarks must be reported to the HCP. So another top missed NCLEX question, which assessment finding should the nurse report to the healthcare provider? A 6-month-old with a birth weight of 8 pounds and 5 ounces, who now weighs 14 pounds and 4 ounces. Remember, at 6 months, the birth weight should double. So 8 pounds and 5 ounces should be around 16 pounds and not 14 pounds, 4 ounces. So this baby is showing delayed growth and development. So we definitely need to report this to the HCP provider. Now, Kaplan mentions 8-month-old client, possible delay in growth and development. My child has almost doubled the birth weight. No, doubling the birth weight, remember, should be at 6 months, not 8 months. So we definitely see a delay in growth here. Now for nutrition, breast milk or iron fortified formula is recommended. Never cow's milk. So remember, no cow's milk for infants. And solids should begin at 4 to 6 months, typically when the infant can maintain control of their head and neck. And be sure to write this one down here. Only one new food per week. Huge NCLEX tip. This is done to assess any unknown allergies and to take it easy on the immature GI tract. Now, in terms of infant assessment, starting at the head and then moving down. So for the head, at birth, the head circumference is slightly bigger than the chest, but equals in size around 12 to 18 months. Now, it's important to know that newborns also have two non-ossified membranes on the head called fontanelles, or basically soft spots, between the bones of the cranium here. Now, fontanelles should be flat and only slightly pulsate when the baby cries, coughs, or lies flat. These fontanelles should never be bulging at rest or sunken. This is priority, so be sure to write this down. Fontanelles bulging at rest typically means meningitis or any type of increased ICP. And sunken fontanelles typically means dehydration or fluid volume deficit. We must report these to the provider immediately. So Saunders had a question here. A 3-month-old monitoring for signs of increased intracranial pressure. Anterior fontanelle is soft and flat. The most appropriate action. Document the finding. Yes, because increased intracranial pressure will usually see bulging fontanelles at rest. Now for closure of fontanelles, which is a huge NCLEX tip, be sure to write these down. The posterior fontanelle closes by 2 months, and the anterior fontanelle by 12 to 18 months, as mentioned by both HESI and ATI. So just think posterior comes prior, and anterior comes after. Now moving on to respiratory. Be sure to write down these things for respiratory distress. We see nasal flaring, accessory muscle use, abdominal breathing, and even non-productive cough. Once again, these are priority signs for respiratory distress. And a little side note here. For excessive crying, which is another big NCLEX tip, typically new mothers will come seek help for an infant that cries all the time here, not knowing that it's perfectly normal for infants to cry around 1 to 3 hours a day for various reasons, like hunger, thirst, irritability, pain, among other things. So the priority nursing action on the NCLEX, and be sure to write this down. Number 1, we always assess the infant's pattern, frequency, and quality of crying. Remember, assessing always comes first. And it's very important to know that a high-pitched cry typically means increased ICP or some type of brain damage. And this is why it's most important to do assessments before interventions. This is correct nursing process, as it's going to help you as the nurse save the baby's life by assessing the presence of a more serious, deadly condition. So again, don't let the NCLEX trick you here. We do not offer a pacifier or explore a parent support system. This does not assess the baby first. So always remember, we do assessments before interventions on any client. Now switching gears to teeth. The first tooth typically erupts between 6 to 10 months, and the lower central incisors is the first, and 6 to 8 teeth in the first year. Now signs of teething, or basically the tooth erupting through the gums, this can be very irritating to the infant, so we often see drooling and general irritability. So as an intervention, we always do teeth care with a washcloth. Now switching gears to infant reflexes, the top 3 tested to know and to write down is number 1, the Babinski reflex. That typically shows up 0 to 12 months. It's where the toes fan out when stroking the sole or bottom of the foot. Number 2 is the rooting or sucking reflex, seen around 0 to 4 months old. Sucking motion when stroking the side of the cheek or mouth. And lastly, number 3 is the tonic neck reflex, 0 to 4 months. Now this one's a little bit difficult to understand, so listen close. When placed on the back, the head turns to one side and the infant flexes the arm of the opposite side, sort of like stretching out the other arm that the child is facing. So Kaplan had a question here. A 9-month-old. The nurse expects which reflex? Babinski. And HESI had 2 questions. What is the reflex assessed by stroking the outer sole of the foot? Babinski. And how will the nurse assess the rooting reflex? By stroking the cheeks of the newborn. And ATI mentions the big one here. A 2-month-old infant placed on their back and head turned to one side. The infant responds by flexing the arm of the opposite side and extending the arm that is pointing the same direction she is facing. Which of the following best describes this reflex? The tonic neck reflex. And some other general reflexes to know is the Moro reflex, 0 to 4 months old, often called the startle reflex. It's in response to a loud noise or sudden movement. The infant stretches out their arms and legs like they're startled, but then immediately pulls them back into the body. And stepping reflex is 1 month plus, also called the walking or dancing reflex. This can be seen when the baby is held upright or when the baby's feet are barely touching the ground, kind of like they're dancing. So go baby, moonwalk it, oh yeah. Okay, the next one is the palmar grasp, 0 to 3 months. This is also called the grasp reflex. So infants will grab onto any object placed in their palm, be it a finger, a toy, spoons, money, or even that new Louis Vuitton bag. Ooh, baby, you got some style. Okay, now the last one here is the plantar grasp, 0 to 8 months. Very similar to the palmar grasp, but placing objects under the toe, the infants will curl their little toes around the object in attempt to grasp it with their plantar reflex. Now moving on to GI assessment. During the first week of life, it is fairly common for newborn babies to have some small amount of bloody mucus inside their stools, and then a yellowish-brown colored stool. So trust me, newborn mothers are very, very concerned and rush for medical advice when they see bloody mucus. So a big NCLEX tip here is bloody mucus in a newborn's diaper. What do you do? So remember, we always assess. So the big intervention here is to continue to monitor the color, amount, and consistency. Because remember, assessment always comes first. Now, if it continues, then it could mean that something is very wrong, like constipation, gastritis, and even E. coli, among other things. So Hesse had a question: what color stool would the nurse explain to expect on the 3rd day of life? Yellowish brown colored stools. Okay, now switching gears to toddlers, age 1 to 3 years old, for their physical exam. So for growth, height should be around 3 inches per year, and for weight, an average yearly gain of 4 to 6 pounds per year. Now a big NCLEX tip here is at 30 months, or basically 2.5 years, weight should be 4 times greater than their birth weight. So be sure to write that down. The key term again is 4 times greater than birth weight. And we also see weight gain slowing down during and after the toddler years. So a top miss NCLEX question here: a 39-month-old child, which finding requires immediate follow-up with the primary care provider? Weight is 6 times greater than birth weight. No, it should be only 4 times greater. So that's a big old baby. Now, family and meal habits need to be discussed with this patient to avoid future obesity and related issues like diabetes. Now for the head circumference increases by 1 inch, or 2.5 centimeters, during the 2nd year, but then slows by half until age 5. And chest circumference exceeds abdominal circumference by age 2. The body begins to sprout up like a green plant, with taller, more slender appearance. Now, as far as nutrition, the child should already be eating solid food, and we always limit milk to, write this down, 16 to 24 ounces per day, or basically 2 to 3 cups of milk per day. And for juice, that is limited to 4 to 6 ounces per day. So make sure to limit these liquids to these ranges, as growing toddlers should be weaning off liquid nutrition and eating more and more solid foods. Okay, now in terms of safety teaching, this is huge. Be sure to write this down. Choking hazard is always the number one because airway is always number one on the NCLEX. So we always cut food into bite-sized pieces. Sit the child up when eating and cut food into bite-sized shapes, not round. And we always avoid round foods, so be sure to write that down. So for example, some big foods to avoid is popcorn, raisins, peanuts, grapes, even carrots that are raw, and even hot dogs and celery and candy. Remember, the airway of the child is small, about the size of a drinking straw. Since young children love to place everything inside their mouth, you can see the problem here. Huge risk for airway blockage. Next up is burns. We always cover electrical outlets and face handles on the stove inward. So stovetop pots and pans. These should be toward the back of the stove. And we always lower water heater temperatures below 120 degrees Fahrenheit. And lastly here, apply sunscreen SPF 15 or greater before going outside and reapply it every 2 to 3 hours while out in the sun. Now for drowning, always a big concern. We close bathroom doors and never leave the child alone near a body of water. This is huge. Often bathtubs, toilets, and pools are the most common places where drownings occur. And for crib safety, always place an infant on their back to prevent SIDS. Never on the stomach, so be sure to write this down. Prone position, unattended, means a high risk for SIDS, that sudden infant death syndrome. Nothing else should be inside the crib. So don't put the infant to bed with a bottle. This means a high risk for dental caries, or basically cavities. And lastly, a big one here is we remove crib musical mobiles at 4 to 5 months, since at this age the infant learns to stand up and ends up strangling themselves on the strings connected to the musical mobiles. And next is car seats, always a family favorite on the NCLEX here. Car seats should be rear facing in the back seat at 45-degree angle. Never place the car seat in the front seat, and never place padding under or behind the infant or child in the car seat. I know this might be more comfortable for the child, but it can actually eject the child during a car crash. And around 2 years old, a convertible car seat is recommended and can be facing forward. Now it's used until about 30 pounds or 13.6 kilograms. Then we transition to a booster seat around 8 to 12 years old, but only if the following criteria is met. The child must be 4'9" or 4 foot 9 inches tall and 35 to 80 pounds, or basically 15.9 to 36.3 kilograms. Now moving on to preschoolers and kindergartners, 3 to 6 years old. The growth should be a height of 2 to 3 inches per year and a weight gain of 4.5 to 6.5 pounds per year. And as far as nutrition, they require 50% less calories than adults, with 5 servings of fruits and veggies per day and protein, carbs, and fats. You get the idea. Now for activity and sleep, 1 hour of physical activity is recommended, at least per day, and allow about 12 hours of sleep each night. Remember, develop consistent bedtimes at around 7 p.m. and avoid sleeping with parents. I know this one is always a hard one. Now in terms of beliefs, a little side note here. We talk about this more in the Piaget's theory video, but preschoolers have magical thinking and often don't understand cause and effect. For example, a common NCLEX question asks about a 4-year-old's beliefs. Select all that apply. They believe that an injury is a result of misbehaving and often feels responsible for being placed for adoption. Huge NCLEX tip. Remember, this age group doesn't understand cause and effect and often feels responsible for the things that happen to them, even if it's outside their control. Now, Saunders mentions a 4-year-old child. When experiencing pain, the nurse anticipates, views pain as a punishment, blames someone else for the pain, and believes that the pain will disappear magically. Yes, remember magical thinking with this age group. Now, switching gears to ear assessment. Less than 3 years, we always pull down and back. And over 3 years, we always pull up and back. So the memory trick, when the child is growing up, then we pull the ear up and back. and less than 3, then we pull less, basically down and back. So Hesse had 2 questions. Position the pinna to visualize the eardrum of a 4-year-old child. Up and back. Yes, remember, growing up, we pull up and back. And question 2, direction to pull the pinna of an infant during an ear exam. Down and back. Yes, again, less than 3, then we pull less. Down and back. Now moving on to school-aged children, 6 to 12 years old. The growth is very similar to the preschoolers, with a height of 2 inches per year and an average yearly weight gain of 4.5 to 6.5 pounds. Now for activity and sleep. Activity, peer interaction grows, as well as competitive and team play. And for sleep, they require around 9 hours of sleep per night. And in terms of safety, we always recommend when riding a bicycle, they wear helmet and pads, and ride in the direction of traffic, as well as wearing colorful fluorescent clothes. And use a car seat until around 4 feet 9 inches tall, and never place in or near a pool alone. Huge risk for drowning. Now more specifically on physical examination, we always treat them like mini adults. So the same head-to-toe assessments, the same pain scale assessments, the same subjective assessments, like asking them how they feel or asking them their symptoms. Now a big one here that you should write down is explain the results of the exam to the child at this age. Remember, they're very curious and they're learning logic and processes. So if you don't explain the results, good or bad, they may believe that something's really wrong with them, regardless of the real results. Now another one to write down is we always respect privacy. Big NCLEX tip. Be sure to write this down. For example, when a child requests to be examined without a parent present, we must honor this. Now a lot of students got that wrong, so don't let the NCLEX trick you and always respect privacy of the school-aged children, 6 to 12 years old. Now for a top missed NCLEX question here. An 11-year-old client with abdominal discomfort. What are the best actions during a physical exam? Select all that apply. So before looking at the options, remember, we must treat them like a mini adult, between 6 and 12 years old. So this question says an 11-year-old client. Now looking at our options, complete a full head-to-toe assessment in the same way as an adult. Explain the results of the examination to both the parent and the child. Yes. Ask the child to describe their primary symptoms. Yes, in the same way as we do with adults. And lastly, respect the request to be examined without the guardian present. Yes, a big one is always respect privacy. Now moving on to adolescents, 12 to 18 years old. For growth, boys stop growing between 18 to 20 years old, and girls stop growing 2.5 years after their first period, called menarche. So Hesse had 3 questions here. Growth difference between girls and boys. Growth in height ceases 2 to 2.5 years after menarche in girls. And question 2, general puberty age for girls and boys. 10 years for girls and 12 years for boys. And lastly, a 16-year-old girl who has not started menstruation. Refer the adolescent for an evaluation. Now moving on to activity and socialization. The priority intervention during hospital stays, and I'd be sure to write this down. Encourage meeting with friends and peers. Huge NCLEX tip. This age group, 12 to 18 years old, needs socialization and peer support. This is the primary way of how they develop. So once again, be sure to write it down. Encourage meeting with friends and peers during hospital stays. Now, as a big side note here, we do not recommend socialization for these main conditions. So be sure to write this down. Number 1, immediate post-op, or basically after surgery. Number 2 is clients who are immunocompromised. Very common for clients with cancer on chemotherapy or radiation, and even those on immunosuppressant medications. And very lastly, number 3 is clients with contagious infectious disease. The last thing we need is a group of friends visiting the hospital and now they get this infectious disease. Big no-no. All right, that wraps it up. Thank you so